one of the most obvious indications that we will think about is that of the distorted corneal diseases, because at the end of the day, these are rigid lenses, right? But they have the virtue that we vault the cornea and we land on the conjunctiva that overlies the sclera, which makes these lenses so comfortable. Because these lenses are filled with preservative-free saline and we fill this reservoir, these lenses have a beautiful application for therapeutics. Some of us have coined this like a liquid bandage because they have this wonderful application into ocular surface diseases. When are these lenses perhaps a poor indication or not an indication for some of our patients? When we have a patient that comes to clinic that has edema at baseline, and such edema is really non-transient unless there are surgical approaches to treat this, scleral lenses will likely make this edema worse. The edema can get worse with wear time. And cases like this, it's like Fuchs dystrophy, in some cases of pseudophakic bullous keratopathy, or in cases of failing grafts. So keep this in mind, because if we start putting scleral lenses perhaps in a Fuchs patient that's pretty advanced and is not status post-graft, is a very poor candidate, and the edema it's likely to get worse. Nominally, a lot of the patients that we see for pediatric, it could be neurotrophic keratitis, but it could be Stevens-Johnson's patients. I have seen some pediatric graft versus host patients. When we're dealing with neurotrophic keratitis, these patients tend to respond better to scleral lenses because they don't have sensation. It's easier for us as clinicians to manipulate their eyes and apply lenses and remove, etc. But when we're dealing with babies or kids that have sensation, and at baseline they have a lot of photophobia, they're in a lot of pain, it's what we call the psychology of scleral lenses. Even though nominally we know they're candidates for these lenses, they might not be ready for them because they may have a lot of anxiety to the process of application or fear of this lens coming to their eye. And sometimes even the sensation of saline, they can have a reaction of surprise. Perhaps they might not be ready at a certain point. They might come back when they're a little bit older and then try them again. Invisible pain syndromes is a very important topic. When you see a patient that comes to your clinic and has dry eye symptoms, but when you assess the ocular surface, the signs that you see objectively in the cornea really don't correspond to the symptoms. A patient that has no signs or very little signs in compared to the symptoms, keep at top of mind that potentially these patients may have something else going on, like this case that I'm showing you. It's actually a patient that I saw for a consultation 2 weeks ago, post-RK, that had significant dry eye symptoms, but when I looked and I stained the cornea, really very little signs. That is usually the etiology is not really dry eye, true dry eye, but rather a neuropathic pain component. You should know that many times scleral lenses are not great for these patients. In other words, they have this hyperalgesia. Everything is heightened. All their sensations are heightened, and tissues that are typically non-sensory, like the sclera and the lids, they might have this hyperalgesia, and the lenses will bother them. If you start fitting them, you're probably going to think that you don't have a good fit and order lenses and after lenses after lenses, and it may take you a little bit longer to get to that fit, and yet the patients will say, this is not comfortable. Usually these patients require management by a pain neurologist, so just keep this in mind. How do we navigate scleral shape? Our good friend and colleague, Dr. Greg Denier, published a paper, and they looked at the qualitative assessment of scleral shape patterns using a wide field ocular surface elevation topographer to assess patterns of scleral shape. What they found is that very minimal shape, the least abundant shape in the sclera is actually that of a spherical sclera. Yet a lot of the trial lenses that we have in the market today are spherical. It is possible for us to find toric scleral shape patterns around 30%, but the vast majority of the scleral shape patterns that was found in this study was actually that to be a quadrant specific shape. And this is actually 65% of these shapes. So this is very important to know as we dive into these technology and want to fit better these patients. So how do we approach this fitting, right? So we have our traditional trial-based lens fitting, but we also have now the use of technology that helps us navigate these scleral shape patterns. When we use trial-based designs, we have in the market today spherical trial lenses that are base curve dependent, that they use the base curve to raise or raise the sag of the lenses. But we also have designs that are toric and they're base curve dependent, but also base curve independent. These are designs that we can manipulate the central sag independently from the base curve. and where the base curve is really limited to manipulating that peripheral corneal region. And more recently, we have the advent of quadrant-specific trial lens designs that are data-driven in nature and can help us navigate most of those scleral shade patterns. Fast forward in time, in 2013, we shed more light. And then more recently, in 2015, a clinic that is associated with our clinic published, after being in our clinic and learning our protocol, published a standardized method on how we use these scleral lenses to heal this recalcitrant defects. You can go and see cases where you have an epithelial defect like this, and in a matter sometimes of weeks or sometimes sooner, you can actually see that they heal. But I want to call your attention and keep an eye, because even though this sounds wonderful and it sounds like it's good for everybody and for most cases, but some cases you need to keep an eye out for these weird staining patterns, defects that are not responding to scleral lenses, because for the most part, they will tend to respond. You should always have at the top of mind, whenever you have an epithelial defect, that there's not an HSV etiology behind these. So if you have weird staining patterns or defects that are not responding, always have a top of mind HSV. And obviously the approach is going to be very different than the one that I'm just talking about right now. Is it possible to use these lenses and these bowl as a drug delivery device? Well, these papers that I just referenced, where we were using the scleral lens as an off-label treatment to heal these defects, we were applying 1 drop of preservative-free antibiotic, moxifloxacin in particular, because it doesn't contain preservatives, in the lens bowl as prophylaxis. This was a last case resort, so we were worried about infections because we were having these open wounds, if you will, or defects. We're having these patients sleep with them. And so an indirect supporting data is actually these earlier papers, because we did not see any cases of reported microbial keratitis. There's no direct evidence that actually drug was being delivered, but indirectly we said, okay, perhaps the moxifloxacin somehow was active in the bowl and there was some protection there. Other studies from our clinic, I was actually fortunate to contribute to this publication back in 2009. Perhaps we can think this of more direct supporting data where we can claim with a little bit more of confidence, even though we don't know the pharmacokinetics behind this, that these lenses are a great option for drug delivery. These were, again, cases that last case resort that were not responding to conventional therapy, and they had active neophrons and active neovascularization. Again, this is off-label. We consented the patient and we monitored them very closely. We used compounded preservative-free Avastin, and we put a drop of Avastin in the lens reservoir. We saw that these patients responded, where we went from this scenario to the scenarios that I'm showing you here. And even we started to see also a benefit in vision. And more recently in 2018, there was a long-term outcomes of patients from our clinic that had this treatment approach, where we reported 13 patients. Out of 13 patients, 12 had regression of neovascularization, and up to 10 had improvement in visual acuity with no cases of microbial keratitis. And more recently, as I told you earlier, even though we do not encourage these lenses to be used in active cases of microbial keratitis, a paper from a group in Mexico is starting to shed a little bit light into the use of these lenses, where they put a drop of moxifloxacin not as prophylaxis as we were doing back in the day to heal defects. They cite our paper as a reference and the basis for why they thought about doing this, but instead they actually used it actively to treat microbial keratitis. And out of 12 eyes of 12 patients, 3 eyes they discontinued because 1 eye did not respond and 2 eyes had mycotic infections, but the other eyes that had bacterial infections actually had infections resolved at the final follow-up, which was 1 month. So there's more of a direct supporting data that these lenses are a good reservoir for drug delivery. And so lid crutches, I'm not saying that we should use scleral lenses to treat every type of ptosis. There are other approaches, other treatments that are less invasive or much more faster, perhaps more efficacious. But in cases like this, like a paralytic lid ptosis, the fact that these lenses are bigger, the fact that we raise the vault, that we don't touch the cornea, inherently, they might be a good option application for cases of paralytic lid ptosis. You can see this a patient of mine who had a paralytic lid ptosis, and I used this lens because, again, it was a last resort. They couldn't do more surgery, that there was too many risks involved with this particular case. And some of you may be concerned about this approach because we're increasing the sag of the lens so that when the lid drops, it's actually the increase in sag. This is going to help the lid kind of be held. Is this physiologically compatible? Am I going to be inducing hypoxic negative outcomes like edema or neovascularization? So over the course of 9 years, not only we did not see any signs of edema. You can see how clear that cornea is, edema or neo, but we actually start to see that the cornea, these opacities were actually clearing up. So perhaps it gives us a sense that these lenses could be an application for some of these cases where other things may not work. Speaking about clearing of opacities, like I showed you over the course of 9 years, I would never recommend that we use or fitting a patient just for the sake of clearing an opacity like this. This is not my intention when I bring this up this morning with all of you, but I think it's important for you to know and be aware that when we adequately fit a scleral lens in a way that is physiologically compatible, induce conducive good physiological endpoints, meaning we're not too tight, etc., it is possible to see scenarios like this, where we go from a very dense opacity over time, just daily wear of lenses, no adjuvant therapy, no use of steroids. It is possible to see these endpoints. This was a pediatric patient that I started to fit, one of my first patients back in 2005, 2006 in the clinic, and it started to shed some light of what was possible. And this other pediatric patient, familial dysautonomia, going from this type of opacity to this over time. It is amazing to see what is possible with these lenses. And we published a series of cases where we were actually able to clear these chronic opacities. So is it just possible to see this clearing of opacities in ocular surface disease? What about the irregular cornea? Well, I show you a patient here that has keratoconus with very significant and advanced VLK, vascularized limbal keratitis, but also has lipid keratopathy. And over the course of 4 years, just with daily wear, no adjuvant therapy, we actually see regression of that significant VLK, but actually we see regression of that opacity and lipid keratopathy. And if we wanted to see other cases of irregular cornea, check this case here is another keratoconus patient that we started to fit from a corneal lens complication. We just wanted to vault the cornea and just protect this cornea from this significant neo, almost close to the visual axis, lipid keratopathy and opacities. And, just what happens over time without us even knowing that we were going to get these outcomes. In a period of 2 years, you cannot even tell that it's the same cornea. And the last thing I will say of higher order aberrations is actually an emergent technology. And why are scleral lenses a good application for this? And that is because we now have the ability to really stabilize these lenses in a quadrant-specific manner and really kind of lock that lens fit as best as we can, but also because we have the ability to center the optics or decenter the optics to really align the line of sight, and allows us to go from this scenario to this scenario.